Hello. Thank you, ma'am, and I thank the organizers of the DPHI Con for having invited us to this important topic. The organizers have taken very good care of us, including Dr. Nirmal, Mr. Mahil Vannan, and Dr. Sriram, and Dr. Saranya, and so on and so forth. And I also would like to thank the Department of Public Health, or the Directorate of Public Health, for having considered mental health as one of the important public health concerns. Mental health was always an invisible epidemic. Even during COVID, we saw what happened. So I would not like to stand between you and lunch. So I'll skip through the slides. Maybe I'll take about 10-15 minutes maximum to go through this topic. I am actually not a public health professional. I am a clinician. I see patients day in and day out in the hospital, but I'm interested in this public mental health or public health. That's how we have done some work with many underserved states of the country. First, in my first half of the presentation, I'll be talking about how has the public health scene of mental health in India evolved. And in the second half, I'll be talking about what work NIMHANS has coverage. And so in alignment with that, the National Mental Health Policy also talks about universal access to mental health care. In fact, a couple of states have come up with the state level mental health policy. For example, Meghalaya has already, based on this, has come up with state mental health policy. I know state of Maharashtra is working on the state mental health policy for the state of Maharashtra. Likewise, many other states also are coming. Reducing the risk of suicide, protection from harm and respect for rights of persons, to reduce stigma and so on and so forth. There are so many objectives of the National Mental Health Policy. And these are the guidelines under which the NMHP is functioning now. It's a very elaborate guideline. You can see the allocation for various issues under the National Mental Health Program. You see the manpower development, manpower details that are approved at the district levels, at the CHC level, at the PHC level, and so on and so forth. These are the list of psychotropic medications that ought to be present at various levels. And this is the direction on the public-private partnership as well. So next is the Mental Health Care Act. There was a wonderful discussion on the public health care of Tamil Nadu. Just previous, who are the primary healthcare workforce? There are medical officers at the PHCs, CHOs at the Ayushman Arogya Mandirs, ASHAs, multi-purpose workers, and so on and so forth. The objective of this capacity building is to integrate mental health care into primary care and the general health care. Taluka Mental Health Program. We are also the Center of Excellence for the National Program of Climate Change and Human Health. And of course, the National Telemental Health Program, or the Telemanas. I'd be talking about these things. So Bihar, we started working in 2016. Not even a single psychiatrist was there for the DMHP. Bihar is a very big state with 38 districts. And we partnered with AIIMS Patna to impart, part-time diplomas for working for doctors, MBBS doctors who are working at the district level. And you could see the impact, you could see the gradual increase in the number of patients that they were able to identify and pick up and treat at the primary care level over a period of 1 year. This was a 1-year course. And we also did some work with the prison medical officers, the prisons of Bihar. Here also you can see the number of patients that were seen, the skill level increased from 63% at 6 months to about 75% at 12 months after the training. And about 8% of the patients who were seen in prisons, they had psychiatric problems. The trained doctors were able to identify and treat them. This is an example in the state of Chhattisgarh. The footfalls you could see. Chhattisgarh, we are working for the past 7 years. The footfalls have in the primary care clinics has risen from 70,000 in the entire state to about 7 lakhs in the next 5 years. And this is one impact that I would like to state. And in the state of Uttarakhand, we have had an MOU with AIIMS Rishikesh and the government of Uttarakhand. We three are working together to improve the training of primary care doctors at the district levels, both in Bihar and Chhattisgarh and Uttarakhand. We can proudly state that there are actually NIMHANS trained doctors providing service in all the districts, especially in Chhattisgarh. All PHCs, there are more than 2,000 PHCs are there. In every PHC, there is an NIMHANS trained doctor delivering mental health care service. As regards the impact, after 1 year of training in Uttarakhand, approximately 11% of outpatients in the PHCs are identified to have mental health problems. That was, and these are some of the other publications that was there. To talk about NIMHANS Digital Academy, it was inaugurated by the Honorable Health Minister in 2018. Currently, we are offering 34 courses, 7 diplomas and 27 certificate courses. In fact, NIMHANS Digital, you can see the number of professional enrolled till now has crossed 1,75,000, out of which about 1/3 are accredited from various diplomas and certificate courses. And this is just the doctors' number enrolled are about 18,000. And
another initiative, digital mental health training of medical officers, CHOs and field level workers was undertaken, wherein about 42,000 participants were trained, 7,300 doctors, 18,000 nurses and 16,000 field level workers. So we were able to impact about 50 million lives by touching their lives. There was increase in the prescription practice of the primary care doctors, ranging from 15% increase to 58% increase. There was change in practice of educating patients and family members among the CHOs also. Which, of course, the range is very wide, but that is an impact that is 5% to 29% increase is what I would say. Next, I would talk about now the district mental health program is there. We need to move towards Taluka mental health program, because almost 95% of the districts are covered DMSP. So we need a model for Taluka mental health program, and Ashrayas Trust is one a trust that has come forward to fund this. We are working with NIMHANS as the hub and AIIMS Rishikesh as a hub. We have taken two talukas and we have had a very good impact till now. About 2 years we have been training. You could see the treatment gap has reduced from 90 to 60% in one taluk and from 93 to 53%. Just like that, suicide rate has reduced by 20% in 1 year. The clinic footfalls has increased in the clinics of this Naman. And National Program for Climate Change is another program in which NIMHANS is closely working with all the states and the central government. Some of the IECs that have been developed. Telemanas, as you all know, it has started from October 2022. More than 26 lakh calls have been serviced till now. More than 2,000 professionals have been trained. More than 530 on-site trainings have occurred. And there are actually some barriers which we are trying to work out. So in the last 2-3 slides, one is the public mental health. When you consider public mental health of India, this is my personal opinion. I am subject to change. I believe that change is possible. Sustained efforts are required from multiple stakeholders. It could be health administration at both state and district levels, trainees, incentivization, trainers, constant monitoring, innovative methodology, patience and perseverance. There are both opportunities and future prospects, I would say. Establishment of more regional digital academies, conversion of clinical beds into teaching beds across many mental hospitals in the country, AI-driven support, integration of service delivery through Telemanas and district mental health program, research and monitoring framework, and development of composite mental health indicators. These are some of the opportunities and future prospects. I'd like to end, by stating this. Thank you.
Thank you, sir. We can understand the phenomenal work done by a single institution for the in the community perspective.
Yes, sir.
Because what a PHC can do, tertiary care institution cannot implement. Similarly, the vice versa. So now I can understand that you have rightly pointed out that change is possible. And the patience and perseverance. Now we can see once the district mental health program is implemented, particularly in Tamil Nadu, our experience, people started responding to the availability of physician.
Yes, sir.
Because we are sending them invitations.
Yes.
Similarly, the Telemanas,
Right.
everything we are doing.
Yes.
But do we have any specific message to the primary health care physicians who are here? You can tell it as a suggestion or advice or whatever it
Yes,
is
sir.
to improve, because intending psychiatric drugs, Suppose if there is no response is minimal, the wastage of resources will happen.
Right.
So what type of intending? Can you just brief?
Yes, sir. A couple of sentences. Thank you very much for bringing up this. We have been working with primary care physicians across the country, and it has been repeatedly proven for the past 50 years that at least 20 to 30% of the patients who come to the primary healthcare clinics, they do have psychiatric disorders, but they go untreated. That is point number one. There are very easy methods of identifying them. There are actually doctors in primary care settings, they clearly know this person does not have any other medical issue, but they struggle to manage them. That is why they keep getting repeatedly patients come back again and again, the drips and other things and Bantac and things like that. So if our primary care doctors are able to identify psychiatric problems, it could be somatization, it could be anxiety, it could be mixed anxiety, depression, substance use. These are the commonly prevalent problems in the primary care settings. They do come with multiple bodily complaints. So there are very clearly identified methods of treating them. That is point number two. Point number three is the psychotropic medications. They are intended. I take your point. It is kind of it should not go waste. But the primary care doctor should know that the response is a bit low. I mean, a bit slow. What I mean is that once they start a low dose of psychotropic medications, they have to wait for at least through three weeks or 4 weeks or 5 weeks, which the quick fix solutions are not there for mental health problems. And once they persevere, and once they patiently persevere, then the changes will come. And there are methods. They could actually contact the Nimhans Digital Academy. We have designed courses for primary care doctors, which can empower them and help them identify these problems and treat them very well. And once the functional treatment gap at the primary care centers are reduced, then the treatment gap also will reduce. This is my message.
Thanks for your words, sir. We would look forward to have our doctors trained, at least through online.
Absolutely. It is online course only, sir.
Because we want to make it very structured.
Yes.
Because everybody, we have 6,595 doctors, 7,000 doctors with us in the primary health center alone. So if they get an exposure.
Absolutely.
And we would look forward to work with you.
We will be very welcome, sir. Thank you,
sir.
Thank you.